Director of the Clinic. Welcome to the fifth of our presentations for the RHAU Rural Behavioral Health Support Series on the topic of substance use disorder in rural Utah and crisis intervention, which will be presented by Dr. Elizabeth RHAU. The series is supported by the Rural Health Association of Utah, Project ECHO, and Cambia Health Solutions, and presented by the Moab Free Health Clinic in Southern Utah University. Please welcome Dr. Elizabeth RHAU. She's the professor of psychiatry at the University of Utah School of Medicine in Salt Lake City, and seeing patients at the Huntsman Mental Health Institute and University of Utah Hospital. I will let her continue to introduce herself and continue with the presentation.
Great, thanks, Kate. Well, I'll go into more about me as we go along if need be, but I'm going to start the slideshow. And so welcome everybody. And this is a topic that some of you know, it's near and dear to my heart, even though I'm not so much of a rural person myself. As far as having lived in rural areas, I certainly come from a family with a very rural background in one side of my family. And so, but that's in the Southeast, which is a whole different ballgame than the frontier states in the West. So I thought I'd start out with just a little bit of information about some trends. And I'm not going to belabor this because this isn't really what we're here to talk about, but I think it sets the stage for what I will say later. So, you know, we have a lot of changes that are happening in the world of drug use and drug dependence or substance use disorder. And some of you may have seen similar slides to this because I kind of stole them from the DEA presentation that I saw not too long ago. But the DEA basically says that there's unparalleled accessibility and availability of high potency drugs. And this is really unprecedented. It has never been seen like this before by the DEA. And the seizures have gone up. The cartels are more and more powerful and rich. The market is kind of oversaturated, and pills have gone from $20 down to $1, and the cartels are scrambling because, you know, they're a business, and so they want to increase their market share and appeal to new customers. Unfortunately, some of those are children. But the thing that we see clinically is that heroin, for example, is difficult to find now. The opioids you see on the street are really mostly synthetic drugs that are manufactured in Mexico, mostly fentanyl. And we had developed a lot of strategies, like for withdrawal for heroin and other opioids like oxycodone, and these don't really apply very well to fentanyl. There's not much prescribed fentanyl on the street. It is a prescription drug, but that's not what you're seeing on the street. It's all the illicitly manufactured fentanyl in pressed pills and other forms. The pills on the street, many of them, the majority of them, contain a lethal dose of the drug. They are seeing, I don't know about Utah yet, but in Wyoming, they're seeing an increase in DUIs from fentanyl. And like I said, this drastically changes our withdrawal management. Kratom is a legal over-the-counter substance in Utah. It's available at convenience stores, but it is an opioid, and it causes opioid-like addiction and withdrawal. And so some of you may be seeing people come in on this particular drug, which can be managed with buprenorphine. There's also a lot of mail order drugs, and they're over-the-counter drugs like tianeptine, which is also known as gas station heroin, it's a European antidepressant, but it's not available in this country legally through, the FDA. It's got opioid and sedative properties when taken in high doses. If you take it in the therapeutic doses, you have a little bit of this, but if you take it in high doses, it's very, very potent. Sorry, I keep hitting the wrong button here. Phenibut, some of you may have seen, it's a sedative that is also sometimes it rises and falls. And then there are a lot of designer benzodiazepines that are on the available online or sometimes on the street. These are Schedule I drugs now. Methamphetamine, it's our old reliable. It's ubiquitous in Utah. Sadly, we don't have a lot of effective treatments. We don't have like a Suboxone or buprenorphine for methamphetamine. There's nothing that effective or reliable. There are some treatments like bupropion or Wellbutrin and naltrexone in combination. There's a lot of attention being paid to how to treat methamphetamine addiction, but not a lot of successes to report. There's a lot more involvement of methamphetamine in overdoses. And one of the things that may be leading to this, but one thing that is actually out there is that the D-methamphetamine, which is, so methamphetamine has two forms that are sort of mirror images of each other, and the D-methamphetamine is more potent and reinforcing. And often the street methamphetamine would be a mixture of these two, but more and more it's becoming higher, it's having a higher concentration of the D-methamphetamine, which is more potent and more reinforcing. There are some other treatments that are promising, but they're not widely available, like contingency management and transcranial magnetic stimulation, which is very expensive and not covered by any insurance for a drug addiction yet. And contingency management continues to be somewhat problematic because you can't do contingency management and run afoul of federal funders. And it's a tricky thing to navigate, which some groups are trying to change at the federal level. There are not so many designer stimulants out there. There are nitazines, which I don't know that we've seen that much here in Utah, but they're opioids that are 50 times more potent than fentanyl. So just wait and see what happens when those get here. There's also xylazine, which some of you have probably heard of, or tranq, which is really pervasive in the northeastern US, but it is here in the West. It's an animal tranquilizer, and it's actually quite useful in veterinary medicine. So eliminating it or making it Schedule I is not supported by a lot of veterinary medicine folks. And it is something that causes drowsiness and it slows breathing. And when it's mixed with fentanyl or heroin or whatever the opioid of the day is, it's called tranq dope. And one of the things that happens is that you can give someone naloxone or Narcan. It will help the opioid overdose, but it won't help the xylazine overdose. So there's prolonged sedation, and this can be quite problematic for people. And it causes, even if you smoke it, not just inject it, it can cause necrotic skin wounds that are really, really gnarly. And the Grayken Center up in Boston has some great educational materials about xylazine if you're interested in knowing more about that. The other thing that I've seen a lot more of are really severe medical complications, bacterial endocarditis or infected heart tissue from injection, also soft tissue and bone infections from injection, and a lot of complications from these infections. In fact, I've seen people have to have limbs amputated because of these infections and clotting and a lot of complications that occur from using. Also, the thing that doesn't get much attention is that there is a methamphetamine-induced heart failure. And we see this quite a bit at the university on our addiction consult service. And, someone who's been smoking methamphetamine for a while, and there's no length of time that you have to use it for this to happen, comes in and complete heart failure. And it is extremely difficult to treat, especially if people are continuing to use. The damage will continue. We're also seeing a lot more end-stage liver disease, like liver failure, when people need an urgent liver transplant. Generally, this is from alcohol, but I don't remember in my career seeing this many people this young needing urgent transplants. So something is different. People that sleep outside, especially, they can end up with frostbite. If they're in a tent and they're trying to heat it up, they can end up with burns, or there are other ways to get injuries and burns, and a lot of other accidents that can happen related to drug use. Overdose deaths, actually, you probably heard that recently that there was an overall decrease of overdose deaths by 3.1%. But the opioid deaths fell, but the deaths from cocaine and from methamphetamine rose. So cocaine deaths rose 5%, and meth-associated deaths rose 2%. Now, we can't say that the overdose was caused by these drugs, but definitely there is more stimulant involvement in overdose deaths. Luckily for Utah, there has been a decrease overall in the past several years, but we can't rest on our laurels. We still have a lot of deaths. Okay, so just to give you a little viewpoint. So rural challenges, there are many challenges, and I'll talk about these in some depth here. As you probably know, Utah was one of the top 5 states in the US for opioid overdose deaths until the past several years, when the deaths began to decrease for whatever reason. We can't say exactly why, but we put in place a lot of interventions that I think have helped us decrease our opioid overdose deaths. We've already talked about methamphetamine and fentanyl. And the other thing that's interesting is you can't say, oh, Utah uses this or Utah has that, because the drugs used and the problems vary a lot by area of the state. Overall, we have limited access to treatment. Even people with private insurance or Medicaid, Medicare have limited access. There are very few health professionals trained in the care for substance use disorders. And we still have a lot of stigma, with primary care physicians, often resistant to learning more about addiction because they don't want those people in their practice. I see this less in the people who are in training, but definitely in the ones that have been in practice for a while, this is pretty common. So as you all know, some of the health challenges we have in rural areas, especially in Utah, poverty to extreme wealth, especially in places like Moab or other places that are populated by people who want to go to a beautiful area and retire or whatever. No public transportation, roads that are often inaccessible, long travel, delayed EMS services, no or poor cell phone reception. This always surprises people in the East because they're used to having cell phone reception everywhere. Some people don't even have electricity or running water, especially on the Navajo Nation. There's limited internet access, a lot of food deserts. Uncontaminated water is a really hot commodity some places, and availability of groceries, stores, and places to get healthy food housing is really a problem. It's limited at best, but it's often unaffordable or unavailable, especially in a tourist area where everything is being, converted to, short-term rentals and that sort of thing. And people are finding it more and more difficult to find a place to live, and they often can't live where they work. Unemployment is higher in the rural areas. Job opportunities are often seasonal or at least limited, and there's a smaller tax base because of the smaller population, and a lot of other reasons. So mental health wise, we have a lack of mental health services and few mental health providers. There's a lot of restrictions on care with Medicaid. For example, if you have Medicaid and you're in, I'll pick on, like Carmen Emery Grand, Four Corners Behavioral Health, that's where you have to go for your mental health care. And there are very few providers that are contracted out to provide the mental health care anywhere in the state. And even if in the less populated areas, there's not a lot of providers, so it's hard to even contract out because there's not very many choices of how to contract out, of people to contract out with. If you're unfunded, it's even more difficult. There's a lot of restrictive insurance coverage that we struggle with still, with carve-outs and with lack of parity, which we were supposed to have dealt with years ago, but it certainly hasn't been dealt with. Limits on, lifetime coverage, or limits on amounts that are paid, or whatever, no matter what your coverage might be. Telepsychiatry is something that everyone touts as like the answer to everything, but there's not a lot of accessibility even for telepsychiatry in many rural areas. And for example, one of the community behavioral health providers has no full-time prescribing providers and only part-time telepsych prescribing providers. There are a lot of disincentives. Like, one of the complaints that we had when our residents were doing some work for Four Corners Behavioral Health was every time your residents see a complicated patient, they want to refer them to the hospital. Well, first of all, there's no hospitals to refer them to that are close by. But secondly, that money comes directly out of the capitated funds that are sent to that area behavioral health authority. And one hospitalization can take away a lot of funds that could be used to give other services to other people, so that the disincentive is there to hospitalize people, even when they need it. And so communities have to have more inventive ways of managing things within the community, because they just don't have that accessibility. For substance use disorder, more stigma even than mental health. Qualified staff are few and far between, and they're hard to attract and maintain. And it's rare that there's an addiction specialist in a rural area. Moab does have an addiction medicine specialist. That is so unusual. And that's one fortunate thing for Moab, but I can say that the rest of the state, other than around the Wasatch Front or maybe St. George, they're not going to be addiction specialists around. So what happens is, if you don't know an area very well, you don't use evidence-based practices as much. And so people are not getting kind of the most up-to-date treatment. In rural areas, we know that there's a lack of anonymity, and there's a lot of stigma that has to do with some of the issues related to living, in an area with fewer people, and where everyone knows everybody else. And there might be years of history for somebody who presents for treatment, and they may have to fight against some stigma that they're facing from 10 years before even. Private treatment programs are not in rural areas generally, and that's because there's no money for them there. And so nonprofit public funding is the usual way that treatment is funded. There's also less availability of medications for addiction treatment like buprenorphine, and the more recent developments of the ways to give buprenorphine, like the extended release. And there's less of an entrepreneurial approach because there's really not a lot of money to be had in being an entrepreneur in treatment in the rural area. There's a great need, a high burden of mental health and substance use issues, a high rate of suicide, the challenges we've already talked about, low accessibility, workforce challenges, recruitment, and loan repayment, because over and over again I hear, well, I thought I would get a loan repayment, but when I applied, I didn't qualify for some technicality, or it was too much work, or it wasn't, I wasn't going to stay there that long, or whatever. And it's frustrating because that to me would be if it were easier and more accessible, it would be a great way to recruit people to our more rural areas. So we have all these challenges. What can we do to address substance use disorders? And the one thing I want you to hear, first of all, is there's no addiction specialists that are going to ride in on their horse and, save the day in rural areas of Utah. I wish I could say that there were, but one of the reasons we do things like this ECHO is to help people get more comfortable and more adept at working with substance use disorders, because there aren't those resources that are available or likely to come anytime soon. So the first thing that everybody can do, and this is sort of like, let's pretend that the house is not burning down, right? Because, if the house is burning down, we're not going to be doing screening. We know what the problem is. But if you don't know, or you're just seeing somebody for the first time in like a primary care setting or in a hospital setting or whatever, screening is recommended, especially for primary care, because substance use is something that can be modifiable, preventable, etc. And it can definitely improve health and patient safety, reduce stigma, etc. And the U.S. Preventive Services Task Force recommends screening for unhealthy alcohol use and unhealthy drug use, and to provide people with brief counseling and offer or refer to services. And that's where we kind of break down in the rural areas. I think we can all see that you can get trained, or you probably already are trained on brief behavioral counseling interventions to reduce use, but we don't have any place to send people often for more intensive treatment. So, and also remember, screening tests are not diagnosis or treatment. And one of the things that I think is a great resource is this link on this screen, where an agency, a clinic, an entity can go to this site and input information about their setting and get a plan that works for you and your clinical setting. So not me saying, oh, you're here and you need this. It's more, oh, you have these resources and challenges, and this is something that can really help you develop a realistic plan for your clinical setting. So I'd recommend checking that out. But in general, what we want to do is use a non-stigmatizing and an open approach, normalize the process, like set it up that we ask all of our patients when they first come in, or once a year, or whatever it is, about their substance use. This is just part of your health assessment, and give facts and offer help. But this all has to be non-judgmental. It has to pay attention to safety first. And the screening, brief intervention, and referral to treatment, or SBIRT model, is highly recommended. And the other thing to think about in any kind of medical setting is critical moments can really motivate people to make changes that they may not have been willing to do before. So pregnancy, acute illness, a family tragedy, or something like that. Even though the negative ones are very sad, they might be a motivator. But you have to be very gingerly about trying to use those as motivating situations. But if you're exploring with patients what motivates them, or what they're concerned about, you can often find things that they're willing to change or not change. And I'm not going to go into the whole SBIRT model. That's a whole different talk. But these are just the basic elements of it. It's brief, universal, and standard screening that targets specific behaviors, and it's in a non-substance use disorder treatment setting. You should have all components of the SBIRT, including the referral to treatment, and they should be supported by research or experiential evidence. So this means you don't pick how you're going to refer somebody, that you give them all the different choices that are out there. These are some of the screening tests. These are very brief. There used to be the NIDA Assist, but it was discontinued in favor of this TAPS tool, which is shorter. And the brief screener for tobacco, alcohol, and other drugs is used for adolescents. And these all cover, the NIDA tools cover alcohol and drugs. The CAGE aid is for alcohol and drugs. The audit is for alcohol. The DAST is for drugs, and the tweak is for alcohol use in pregnant people. And the CRAFT is based on adolescents. And all of these tools are in the public domain, freely available. So you screen somebody, the house isn't burning, you screen them and they screen positive for substance use, then what do you do next? Well, the brief interventions are really the first things. Once again, the house isn't burning, so you're not trying to put out a really big crisis. But this is where you would do brief counseling and patient education. And the goal would be to reduce risky behavior. And in this case, alcohol and or drug use. This should be really short, less than 10 minutes. I didn't include it here, but there are CPT codes for these interventions. And if somebody would find that useful, I can put that back in the slide deck, or I can send it to Carissa and she can post it. This should be short and motivational, respectful, and practical. And this is one place where, working in a rural area or knowing the area, you can be much more practical about what is doable for people, as opposed to our residents who would say, oh, we need to put this person in the hospital, when that's just down the street in Salt Lake City. It's certainly not down the street in rural Utah, and it's not really practical. You also focus on reducing alcohol consumption, binge drinking, illicit drug use, and tobacco use. And there's a lot of training in these brief interventions, and there's a lot of online material that I could share and I think I may have some of that at the end of the presentation just as a reference. But you want to see if you need further assessment, or somebody just needs recommendations for healthier behaviors, or if they need further treatment, or that sort of thing. And I can't see the chat, so if there's a question that I need to stop for, please let me know, somebody. So the brief intervention, you review the screening, you give feedback, and then it's really important to assess someone's understanding and readiness to change, and then their obstacles to change. So if someone thinks, well, I don't really drink alcohol, I just drink beer, there's an opportunity for some education there that beer is alcohol, for example. Or you may have thought you were using heroin, but you were probably using fentanyl that was contaminated with methamphetamine. So, if there's a drug screen, for example, and there's some surprising or unexpected findings, then give that feedback to the person. You can cover the benefits of decreasing and quitting. Most people have heard this a million times from their family or their friends or law enforcement or whoever. But you could cover treatment options and set realistic goals and leave the door open. It's like schedule a follow-up, even if the person says, I just want to use, 3 days a week instead of 6 days a week. Well, that's a start, it's a harm reduction kind of goal, and that's fine. But supporting their efforts and commitment and encouraging some plan of action. Maybe it's just eating more regularly, or maybe it's being outside and getting into nature, or hiking, or something that they used to do that was a non-drug related activity. And if they have family and friends, encourage support from them, and then provide education and resources. So, brief interventions have to be targeted to the risk level. So, and how complex their problems are. So if someone comes in and they're at a very low risk level, you're not going to say, oh my goodness, you're going to have to go to inpatient treatment. That's totally inappropriate. Now, maybe in 5 years, they'll get to the point where they need something like that, or maybe in 6 months, you never know. The realistic thing to look at for especially primary care and general medical settings is what problems can be managed in your practice and how you address them, especially in a rural area. It's not like you can say, oh, I'm in a family practice in Provo, and I'm going to send you to an addiction specialist that's a mile away that takes your insurance. That's not going to happen. Now, in Moab, you might be able to send them over to the Moab Regional Recovery Center, or someone that can provide counseling, that sort of thing. If you're in Price, you might be able to send them over to Operation Recovery or to Four Corners. But depending on what your practice is and what relationships you have with others in your area, you have to know what you can and can't manage at your level. Which problems need referral to a specialist? Not too many specialists in rural Utah, but if someone does have really severe, let's say, skin wounds from a xylazine or something, they probably, would need to see a dermatologist, at least for telederm and things like that, if possible. But otherwise, the primary care folks are going to have to manage those problems on their own and learn what they need to learn on the fly. And also be aware, when does somebody need emergency care? So back to the brief intervention, this is a nice short acronym for the FRAMES model. You give feedback, you emphasize the responsibility of the person, that it's their choice to change or not. Their advice, your advice is to change the drinking or using behavior for health reasons. Give them a menu of options and strategies as you can best brainstorm it with them. It should be a collaborative, kind of shared decision-making process, not like you need to do this. The approach should be empathic. It should be warm and collaborative and reflective. Like, well, tell me more about what it is that concerns you about your drug use, if someone has expressed that. And support self-efficacy and be optimistic. And, people say to me, because I've been doing addiction work for a number of years, they say, how can you do this? It must be so depressing. And I'm like, well, anybody can recover as long as they're breathing, and so as long as someone is alive and sitting in front of me and talking to me, I think that's a big step. And so I try to remember that even when I, often feel like we're able to get into a power struggle, or that their goals are extremely different than what mine would be for their health. There is a program that so I'm involved in the RHAU Collaborative Care Model grant that Casey Shakespeare is also involved in. And we have identified this COMET program. I don't know if any of you have heard of it. It was new to me, and it stands for Changing Our Mental and Emotional Trajectory to Improve Mental Health in Rural Communities. It's not so much focused on SUD or substance use disorders, but mental health, but it's a community-based training program that takes about an hour and a half to 2 hours. And the goal is to move upstream to prevent crises. And there's a link here. Hopefully we'll be having some trainings in this model or this program in Utah in the near future. So just stay tuned for that. So what crisis interventions do we have in rural areas of Utah for substance use disorders? Well, what is a substance use disorder crisis? Really, these are the ones I could think of. I don't know if any of you have others that you want to add to the list, but it's like overdose or toxicity, intoxication, acute medical problems, acute withdrawal, acute psychiatric symptoms related to substance use, either caused by or just in concert with, and then the risk of continued use if someone has a severe medical problem and they're going out to use. In some ways that's a crisis, but if they're cognizant and they're competent, they can make those decisions. Since we do not have a substance use disorder a law that allows us to do involuntary commitment for people with only substance use disorders. If they have suicidal or homicidal ideation, they're agitated and attacking someone or whatever, then we can always do involuntary commitment under those criteria, but not just for the substance use alone, which is not true in some states. There are states that do have only SUD involuntary commitment. So one of the things I encourage you all to get familiar with, if you're not, is the ASAM criteria. The American Society of Addiction Medicine has a level of care criteria for treatment. And this reflects that, someone who's in one stage of their addiction or use is not going to need the same as someone in a more severe stage of their use. And the dimensions that are followed, that are looked at in the ASAM criteria, are the intoxication and withdrawal and anything related to addiction medications, biomedical problems, psychiatric problems, and substance use related risks, and recovery environment interactions. So, this may be, especially if you're in pediatrics, you may be more quick to take a child out of a home situation if there's active drug use and that child might be at risk of overdosing inadvertently, being exposed to, say, fentanyl. And then person-centered considerations, which are new. And these criteria just came out at the end of last year, and so I'm still learning them myself. I am not an expert in this area, but you can see the continuum of care goes all the way from a recovery residence, which is more like sober living on steroids with actual staff, and into outpatient, intensive outpatient, high intensity outpatient, and residential, and then inpatient, medically managed inpatient care, which is really what we do in the university hospital on our consult service, or at HMHI. We do medically managed inpatient. So what do we do in a crisis? What is there? Well, there are not a lot of tools. The ASAM criteria I just talked about. There's medication, there's psychosocial treatments, psychotherapies, there's withdrawal management and specialty substance use disorder care. In a general medical setting, there's the emergency room. That's where a lot of people end up if they have a crisis that's related to substance use. There's hospital inpatient care, could be for medical reasons, for withdrawal, for stabilization psychiatrically, and then there's outpatient treatments. And depending on the level of severity, often, well, you would decide where somebody needs to go in this continuum of care that I just showed you in the last slide, depending on their level of severity. But realistically, where are people going to go in an area where none or very little of this is available? The first thing that I really want to emphasize is everyone in any kind of treatment setting should have naloxone on hand for a possible opioid overdose. So even if someone is using, they come up positive for methamphetamine, or they think they're using methamphetamine, often those drugs can be contaminated with opioids, especially fentanyl. And so everyone should have naloxone on hand. It should be given to the family members of the people you treat if they're involved. And you should become trained in how to use naloxone. There's a lot of hysteria about having to use higher dose naloxone with fentanyl and nitazines. Not a lot of evidence for this if you really get through the hysteria. But just use it. It doesn't matter. Use it, whatever strength you have. And remember that if xylazine gets into our drug supply significantly, someone may look sedated, but it's not. You don't need to give them more naloxone. It's probably a xylazine related phenomenon. And medication for addiction treatment is really the current standard of care, especially for opioid use disorder. It's evidence-based, saves lives. You don't need to treat very many people with buprenorphine or methadone to save lives and to see benefits. But sadly, it's still not utilized in all treatment settings. Prescribers don't want to prescribe it because they don't want those people in their practice, as I said earlier. Many treatment centers will say that they don't accept patients or won't allow patients to be on medications, which is a violation of the Americans with Disabilities Act and also other laws and constitutional rights that people have. So just know that that's not legal. You can't do that if you're a skilled nursing facility or a treatment center, but people do it all the time. Probably won't change until there's some good lawsuits in our state, which there have been in other states, but for now, we're still battling that. We haven't had a lot of new medications for over 10 years. But luckily, we've had a few things that are really helping. There was a waiver to prescribe buprenorphine, and that went away at the beginning of 2023. So now anybody with a DEA number can prescribe buprenorphine. Everybody has to do substance use disorder education that has a DEA number. And there's some more relaxed opioid treatment program regulations that came out this year. And one of the things that a lot of us hope for in the addiction world is that eventually there will be some methadone office-based opioid treatment in the future. Because at present, only in opioid treatment programs that are federally regulated can you get methadone for addiction. So what do they say at the federal level? When I talk to my colleagues in Washington, they say, go to the behavioral health treatment locator or go to the NIAAA alcohol treatment navigator, and you can find all kinds of resources. Well, yeah, that's true. And there are these things. But let's just look at a map. So this is Utah, and you can see that I think we added these up one time. I think it's like 90%, or maybe it's more than that, of all the resources are in this upper part of the state, pretty much along the Wasatch Front. And then if you look at Salt Lake City, people there are not too concerned because there's all kinds of stuff available within driving distance. But when you get down to eastern and southeastern Utah, there's not a lot. There's programs in Price. There's one in Castle Dale. There's the Green River Medical Center. There's 3 things in Moab. I can tell you exactly what they are. And Blanding, there's San Juan Counseling Center. In Moab, there's Four Corners Behavioral Health. And then there's Moab Regional Recovery Center. And then there's also the Multicultural Counseling Center. And I think those are the only 3 that are listed. So the ones in Blanding, the Four Corners and San Juan do not have any prescribers on site. They have telehealth prescribers, and Moab's Four Corners location does not prescribe any medications for substance use disorder. Moab Regional Recovery Center has been doing most of that work since it opened. I don't know how much MOUD or medication for opioid use disorder they do in Green River. In Price, there are a couple of locations where a couple of entities where you can get that treatment. So these are the resources: community behavioral health centers, opioid treatment programs, otherwise known as methadone programs, but they do other things than methadone. Counselors, federally qualified health centers or community health centers, peer support, primary care providers, mental health and SUD prescribers, crisis centers, hospitals, and then referral to higher levels of care. And just to give you some of the examples, the community behavioral health we've mentioned, Four Corners and San Juan Counseling. We have a very unusual situation, and we're actually very fortunate that we have 2 rural opioid treatment programs in Utah. This is extremely unusual and beneficial. There's one in Price with Four Corners. They have Operation Recovery, and Moab Regional Recovery Center also has a methadone program, and they also use buprenorphine. For counseling, that comes from the community behavioral health centers, Multicultural Counseling Center, Moab Regional Recovery Center, and private therapists. And I left one out. There's also Carbon Medical Services has counseling. And that should be included under counseling too. But Carbon Medical Service, Green River Medical Center, and Utah Navajo Health Systems all provide services, and different services depending on where the person is seen, and counseling more related to mental health, but sometimes related to SUD. For peer support, I think one of the things that we have to look at, because we don't have a lot of resources, is that we depend at the university on peer support specialists to help us kind of fill in the gaps. And I think in a rural area, that can be an extremely important way that peer support specialists can help. They're almost like community health workers, and that's what is used in a lot of less resourced countries and areas of the US. And USARA has a lot of these peer support specialists. Others work for other agencies. But the main thing is to make sure that the person has been trained, because it's a really risky thing if you're in recovery and you do peer support without having your own support system. Some primary care providers prescribe buprenorphine. There are not any psychiatrists in eastern or southeastern Utah that I know of. There are a few psychiatry trained PAs and nurse practitioners who prescribe. And then the crisis centers, there are none yet, but I think in probably within a month or so, the Four Corners Crisis Center is going to open in Price, and it's going to be like a 23-hour crisis intervention model, so that people who need more than just being out in the community and saying, here, go follow up tomorrow, can go somewhere and hopefully decompress and get some treatment that will help them not have to go to a higher level of care. Castleview Hospital has a bridge program where people can get buprenorphine in the emergency room. They also do inpatient withdrawal management. That was the first formal inpatient withdrawal program in the eastern or southeastern region. Moab Regional has their emergency room, and they do some inpatient withdrawal management, but more kind of informally, people with medical problems. And then San Juan Hospital and Blue Mountain have, I guess, emergency services for withdrawal. And then, of course, there's the referral to higher levels of care. Good luck with that. This is a site that I developed that is free. You can to access for anybody. You can give this to family members. It has a bunch of information about mental health crises, opioid overdose, family resources, families dealing with active substance use, grief after overdose death, decreasing stigma, you name it. I would encourage you to look through this. There's some great resources from all around the country. So what do? We can check out those treatment navigators, but I would encourage everyone to get to know your peer support services, find out what the mutual support groups and options are in your area, contact the programs. I know that Carbon and Emory and Grand have all written up sort of a resource booklet for their area, and I think that's great. I think that really helps, and I learned a lot from those two resource directories. Get your personal contacts, and some of the people that I'm talking about are on this call. Like Ashley is here from the Carbon and Emory Opioid and Substance Use Coalition. She is a wizard at finding resources, and I think picking her brain would be excellent. The USARA has an ARCHES program where they go into the hospitals to help with people who need peer support. And they don't offer this everywhere, but they certainly have it in Salt Lake. And then the USARA local centers are a big resource. And the CRAFT program for the family members and loved ones is essential if you're not suffering yourself from addiction, but you have someone that you care about who is, or a patient who is. And then learn from like our Project Echo and PCSS, and all these links in the slides will be hot. So I'm going to stop there. I think that I have 2 more slides, which are just some resources. But I'm going to go back here, and this is me. This is how you can get in touch with me. And hopefully some of this has been helpful, and I'll look at the chat. Okay. Yeah, Ashley, we thought that, one of the harm reduction interventions is to help people with smoking instead of injecting, because that does decrease their risk of a lot of infections. Okay. It can increase the risk of lung problems and that sort of thing. But people who only smoke opioids with xylazine can develop the same skin wounds. And let's see, CPT codes. Yes, I can put those, I can send those in, and they can be posted online for all the screening interventions. Any other questions or comments? I guess this is kind of a depressing presentation, because it's like, well, where are the crisis services? Well, We just don't have a lot in rural Utah or rural anywhere, but especially because we're not just rural, where a lot of Utah is frontier, it's even more challenging. And when I describe some of the conditions and the lack of population to my colleagues who are in the East, even in states where they do have rural areas, they cannot wrap their heads around it. It's just foreign to them completely. And I have to confess that I was clueless about many of these issues until about 8 or 9 years ago, when I started to go more into the rural areas, and I learned a lot. And it's like, wow. So it's one of my goals to try to help as much as possible, but realizing that we are very limited. So I'll stop with that. Kate or Casey or anybody else, any thoughts, or did I leave anything out that you wanted to hear about?
No, I thought your presentation was wonderful and really laid out all the resources, even though there are very few, but makes us more aware that we have work to do in terms of bringing more resources.
Yeah, and the importance of partnerships is just amazing, and that's what Ashley has spent a lot of her time, building, our partnerships, because there's just no substitution for that. All right, well, thank you, and I will send those slides to you, Carissa, and also will send the CPT code slide. Okay.
Great, thank you so much.
Okay, thanks a lot. Okay.